Hello, my name is Chris Graham. I'm a urologist with Urology San Antonio, and today I'd like to talk about overactive bladder, but not just overactive bladder in general, but specifically as it relates to people as they get older. All of the features of bladder dysfunction that are present throughout life can become part of the problem and part of what we need to address as people get older, but there's other features, other aspects that come into play that make treating bladder dysfunction a bit more challenging in the elderly population. The types of incontinence are stress, which is typically the cough, sneeze, laugh. You use your abdominal muscles and generate pressure, and that pressure then causes urine to leak through the bladder. The second is urge. That's when you get the sensation of having to urinate. The bladder muscle wants to contract and drain. It's at a time that's not convenient. You say, it's not time for you to drain. The bladder says, yes it is, and it wins the battle. That's usually preceded by the sensation that you have to go to the bathroom and you're rushing to get there and just don't get there in time. The third type is what we call mixed incontinence. That is a combination of the two above. So it can be a bit of both the outlet, which isn't quite strong enough to hold the urine back against activity, as well as the bladder being overactive, and so we have to manage features of both sides of that problem. A fourth type is what's called overflow incontinence. This is much less common, but it occurs when someone's bladder is filled and won't empty. So if the bladder overfills, it becomes much harder to prevent the flow of urine. So it's important to note that the bladder is empty completely before we start treating it, because if the bladder is overfilled, then the treatments that we use to try to prevent incontinence can actually get worse with overflow incontinence. And the last type, last general category is what we call functional incontinence. And that occurs usually when a person doesn't have the mental capacity or the mobility to be able to get to the bathroom. And this is one of those types that's more common as people get older. If you can't get to the bathroom simply because you can't get out of bed and no one's really there to help you, the bladder is going to eventually empty. And so all the treatments in the world for either stress incontinence or urge incontinence are not likely to be helpful for the person that isn't aware that they need to go to the bathroom or just physically can't get there. So in addition to incontinence, I'm going to talk about overactive bladder in general. So overactive bladder means that as the bladder fills up, it will not stay in a relaxed condition and will tend to contract. And when the bladder contracts, it's going to empty. And when you're able to resist the strong urge to go, then we call that overactive bladder dry, which means that you're not leaking or the person's not leaking. Whereas if you lose the battle and there's leakage, we call it overactive bladder wet. So overactive bladder goes hand in hand with urge incontinence, and I will discuss those two together. Now, as we age, there are several things that happen to our bodies that make treating bladder control issues more challenging. The first of these is the muscles in the pelvic floor. They atrophy, they become weak, they become less responsive to our ability to be able to contract them. And I talked about the bladder, the pelvic floor muscles as being like the reins of a horse. The reins won't make the horse go any particular direction unless the horse is trained and the rider's trained. So if the muscles become dysfunctional or weak, or the rider, in this case the person, doesn't really know how to use them correctly, then the horse or the bladder won't respond. And so weak muscles are a common cause of overactive bladder and of incontinence. The second is that as we age, our bladders hold less urine. They'll fill up and get to a point where the bladder will fill full and want to contract at much lower volumes than when we're younger. A number of reasons why this occurs, but the fact is that the bladder just doesn't hold much as much as we age. The third is that the bladder muscle, while it won't hold as much, is more likely to become irritable. And when it becomes irritable, it contracts. So that not only will the bladder hold less, but as it fills, it's more likely to start spasming, and when it spasms, it gives us a strong urge of having to urinate or results in leakage as well. Another problem that goes along with aging is that as our bladders empty, that doesn't occur as efficiently. And so the bladder may not empty as completely. So say the bladder typically will hold 10 ounces. If you're able to drain all 10 ounces, it takes a while for the bladder to fill back up again. But if you're only able to empty 5 of those ounces, the bladder only has 5 ounces left to fill before it's ready to empty again. So ineffective or incomplete emptying leads to having to go to the bathroom more frequently because of that, what we call sort of a functional decreased capacity, meaning that the bladder doesn't seem to hold as much because by only emptying halfway, it doesn't take nearly as long for it to fill back up. One of the problems that we see in all ages, but it's more common as people age, is going to the bathroom more frequently at night. One of the reasons this occurs is that we make more urine at nighttime. The volume of urine that goes into the bladder during the hours of sleep actually increases as we age. There's a hormone that works really well in younger people that tells our bodies to make less volume of urine. The kidneys still do what they do when they filter the blood, but the amount of water that goes into the bladder during nighttime is reduced. As we age, that hormone doesn't function as effectively. We don't get that spike of the hormone at night to make us hold back the amount of urine that we make. And so we just make more urine, which means the bladder fills up more times, which often leads to disruptive sleep. And the point that I made earlier is that what we call with a functional incontinence is that as we age, we don't move as fast. Unfortunate but true. And so if you have less time to get to the bathroom before that bladder is going to contract of its own accord, and it takes 3 times as long to get there because you have to use your cane or your walker or get someone to help you get out of bed, then the risk of having problems increases substantially. And the last feature is unique to men, and as their prostates enlarge, the enlarged prostate increases the risk of the overactive bladder for all the reasons mentioned above, especially the incomplete emptying and the detrusor overactivity. Now there's what we call a mnemonic, or a word that we call diapers. I'm going to go over that in detail over the course of the next few minutes, and it relates to problems that are more common as we age that impact and complicate our ability to be able to treat bladder control issues. So diapers, actually we spell it with 2 P's, and what it stands for is D is delirium, I is infection, A is atrophic vaginitis or atrophic urethritis. The first P is for pharmaceuticals or medications. The second P is for psychological disorders, and especially depression. The E stands for excessive urine production. The R, restricted mobility. And S stands for stool impaction, which is a form of severe constipation. So all of these issues that fall under the mnemonic diapers increases the risk of incontinence and other bladder control problems, and these are much more common in the elderly population. I'm not going to talk about all of those, but I want to talk about a few particularly. The first is infections. As we age, we're more likely to have bacteria in the bladder. Now, bacteria in the urine itself doesn't mean that you have an infection. Normally, urine is sterile, but bacteria in the urine doesn't necessarily mean an infection. It's when the bacteria gets from the urine and gets into the wall of the bladder, gets into the muscle or some of the living tissues, that an infection is actually created. And so the presence of bacteria doesn't necessarily, if someone comes in to be evaluated and they have bacteria in the urine and they have urinary symptoms, the symptoms, such as the leakage, might be related to the bacteria, or it could be completely separate. The bacteria could just be there all the time, and the symptoms are due to other causes of overactive bladder. So often we'll treat the bacteria first based on a culture, get rid of it, and then if the symptoms still persist, go on and look for other causes. So we want to treat the infection first, but what happens unfortunately is a lot of people will keep going back. They just always carry bacteria in the urine, but it's not causing the problem, so they'll go back, be evaluated, they have bacteria, they're treated for the infection, they don't get any better, and the cycle continues again and again, and we're not really looking for other causes. So treating infections and then recognizing when there's truly an infection present is an important part of treating overactive bladder in elderly people. The second of these points I'd like to talk about is atrophy. So atrophic changes, and this relates more to women than to men, atrophic changes occur when the body stops producing estrogens. So the vaginal wall and the surrounding structures, part of the urethra, they need estrogens to survive. So young women have thick vaginal walls that produce a natural secretion that helps to keep the vagina healthy, and that thickened, healthy vaginal wall and the surrounding structures and the added blood supply that goes along with that help to protect. That's actually part of what makes the bladder function correctly and helps to prevent leakage. Rarely does treating with estrogens alone solve leakage problems, but it certainly can help to control infections, and it can help to control at least some of the frequency and urgency that occurs. Pharmaceuticals is a big issue, especially as people get older. There's many medications that increase the risk of urinary problems, and also the medications that we use to treat urinary problems often they have side effects and cause other problems that compete for health. And so looking at medications and not using them simply because someone has a new problem is a very important part of that. In particular, medications that are used for memory or dementia are called cholinergic medications. The medicines that we use for bladder are called anticholinergic. They do just the opposite thing. So the medicines such as Aricept and Namenda, they're turning up the dial on what's called the cholinergic system. And then when we use medications such as Vesicare, Oxybutynin, and Ablex, there's several of them, they do just the opposite. They turn the dial down. So for people that are on both types of medications, we're actually using two medicines that are somewhat ruling each other out. It's important to look at that as part of the spectrum of of overall health care when we're looking at adding medications to treat overactive bladder. Many people are on diuretics as part of their antihypertensive medications. Diuretics are also called water pills. So what they do is they actually force the kidney to increase the amount of urine that's produced to help get rid of water. So it helps to control blood pressure. They're used for people that have a lot of swelling in their legs. So these medications drive water out of the system. So they don't actually cause leakage, but what they do is they result in the bladder filling much more quickly. And so if the bladder fills more quickly, it doesn't take nearly as long before someone has to go back and use the toilet again. And you've already got the problems of your bladder not holding as much, and there's increased urge to go. It just compounds the problem. And very often, these medications are used twice a day. They're given in the morning, so people have increased frequency and urgency in the morning when they're often awake and can manage it. But then they'll get the second dose in the evening. So body's got a bit more water in it. We use a medication to drive out the water as we go to bed. So the bladder is now going to fill several more times during the night because of the diuretic. And so paying attention to not just the use of diuretics, but the timing of the diuretic is important for managing bladder problems. Narcotics are problematic for several reasons. One is because they sedate people. And so if people are on narcotics, especially at nighttime, so narcotics certainly help to reduce pain, but they also help make people more sleepy. And if you're asleep and you don't wake up to the sensation of a full bladder, then by the time the bladder gets the signal loud enough to wake us up, our bladders may be overfilled, and then it's hard not to leak. A more important issue with the narcotics is they cause constipation. And constipation increases the risk of having overactive bladder and leakage. And there's many other medications that are constipating. And any one of these medications are just the natural slowdown in bowel activity that causes constipation to be a major problem for elderly people. These medications can further that risk and make the problems with overactive bladder more difficult to manage. I've already mentioned restricted mobility, and that becomes a bigger issue, especially in people who are bedbound. And most of those people are in long-term care facilities, but some are still at home. But if someone is unable to get out of bed to get to the toilet, and there's no one there to help them, then all the medications and all the treatments in the world are not going to keep them from being able, from keeping them to be able to manage their bladder. And so, if the staff isn't there to participate in time voiding to help get a person to a toilet or get them on a bedpan, then other treatments are not going to be helpful as well. Another issue another time when it's difficult to manage your bladder is after some sort of orthopedic procedure. Someone falls and breaks their hip and has a hip fracture. They twist their ankle, or they've had a knee replacement. It's now, not only does it hurt to move, it takes longer to get to the bathroom, and more likely the bladder issues will appear after these types of procedures. A final point I want to make about restricted mobility is that if people tend to get up several times at night time to go to the bathroom, and they're not particularly awake, either because they're tired or they're on a medicine that sedates them, and they're rushing to get to the bathroom because their bladder is overactive and they don't want to leak, and then they do leak a little bit. Now you've got a wet floor and a person who may not have great balance to start with, who's moving quickly to get to the bathroom. This really increases fall risk, and so I think managing overactive bladder is very important to help reduce the risk of hip fractures and other problems that occur with falls at nighttime. And the last of these, of the diaper mnemonic that I talked about, is stool impaction or constipation. In my mind, this is one of the most overlooked areas of treating overactive bladder. As I mentioned, so many of the medications that people are on nowadays are constipating, and the bladder control mechanisms are often constipating. So someone will come to see me, and they've already been tried by somebody else on one or more of the medicines for overactive bladder, and they're no better. And then by history and by exam, it's reasonably easy to figure out that they've got a fair amount of constipation. Often, just treating the constipation alone will greatly improve urinary symptoms. And so if I see someone, one of the first things I'll do is to try to help manage their bowels, and then see how that works, and then only go further with the bladder if that's needed at that point. So that gets through a few of the specific problems that are more common in elderly people in evaluating overactive bladder. And as I mentioned at the very beginning, once we get past looking at those features, evaluating and treating overactive bladder in the elderly is very similar as it is in all age groups. We look for prolapse, which is changes in the anatomy of the pelvic floor in women. As women age, they will form a hernia where the vagina will often turn inside out, or either partially or completely, and if that happens, the bladder can fall into that space and end up in an unusual position. If that's the case, that may need to be treated as part of the evaluation and treatment of bladder problems. In men, the prostate enlarges. That leads to frequency, urgency, slow stream, retention, which can, as I mentioned earlier, retention can lead to what's called overflow incontinence. And so all these need to be evaluated as part of before we start deciding how we're going to treat someone who's going to the bathroom too frequently. And now, of the types of incontinence I mentioned, the first of those was stress urinary incontinence. It does occur in men, but the vast majority is in women. That's the cough, sneeze, laugh, leak when you lift something up. It's usually small amounts of urine that will leak out with the activity. And the treatments that we typically use are the bladder neck slings, some sort of bladder suspension, the transobturator tape, which is that little mesh procedure that's getting in the news quite a bit right now because mesh does create some problems in a small percent of people. It has really revolutionized how we approach the treatment of overactive bladder. The treatments are durable, and the operations are often as short as 10 or 15 minutes to place one of those with almost no post-operative pain. So for the vast majority of people, they work well. And the few percent of people where they do develop problems, they can usually be managed fairly easily. There's other types of bladder neck suspension procedures. They're a little more complicated, but there's a range of options that can be done surgically. But again, those can be very, very small operations which can treat that. What I do for a lot of folks as they get older is use what are called bulking agents. And bulking agents work by taking the urethra and putting a material in to help take the urethra from this position and just close it down so you get a better seal. I liken it to replacing a washer in a faucet where the washer's cracked. It just helps to improve the seal. And bulking agents can be placed in the office in about a 5-minute procedure that's well tolerated. So based on anatomy and an exam, often these problems can be taken care of, and a success rate is just as high as women get older as when they're younger. Overactive bladder and urinary incontinence, as I mentioned, that can be a little more difficult to treat as people get older. Most of the medications that we use to treat overactive bladder tend to be constipating. So it can worsen the problem. And as I mentioned as well, we've got this balance between the cholinergic and the anticholinergic effects. So a small percent of men and women can actually get worse memory issues, worse problems when they're on the medications to treat the bladder. That's why the medicines that do just the opposite are often used to treat dementia and memory issues. So balancing those two types of effects of medications is very important to pay attention to. Pelvic floor therapy is one of the first treatments that we offer to people, and that's going back to dealing with those muscles, back to the reins of the horse. So I'm not much of a horseman. If I get in a horse, I don't really know how to use the reins, but I'm guessing that I could probably be taught. And so it's easier for a younger person to do the exercises, but often it's a matter of motivation. And while studies show that younger men and women do better with pelvic floor therapy, what I find in my practice, it's about motivation. And so I've got plenty of women especially in their 80s and even up to 90 who've done very well with pelvic floor therapy, but what I do is screen them up front and try to figure out what their motivation level is. If they say, I'm not going to do exercises, then I'm not going to prescribe the therapy. If they're motivated to participate in getting better and they're willing to do the exercises, then they work very well in the appropriate person. The nice part about pelvic floor therapy is there's no side effects. There's nothing lost. If it works, great, and if not, there's no side effects as you might get from medications or from a procedure. Another important issue to treat overactive bladder is just behavioral modifications. If someone is drinking several glasses of water or other drinks in the 6 hours before they go to bed, that fluid's coming out at nighttime. So if someone's primary problem is at nighttime, just changing when they drink their fluids can greatly improve their urinary complaints. Another issue is caffeine. It used to be that a cup of coffee was about 5 ounces. Now the smallest cup of coffee you can get is about 12 ounces. So the 3-cup-a-day tradition is really about half a pot. And so caffeine and other energy drinks irritate the bladder and increase urinary symptoms. Those are just a couple of the behavioral modifications that can improve bladder outcomes. The medications that we typically use to treat overactive bladder are, as I mentioned, are called the anticholinergics. There's several of them. They work well in the right person, and so a trial of these medications is valuable. Because there's so many out there and the pharmaceutical companies are marketing them through television commercials, people will come in and say, hey, I haven't tried Enablex or I haven't tried Sanctura. Occasionally someone will do better on one medicine than the other, but generally if they've failed one, and certainly if they failed two, then just running through the entire list of them is not likely to produce better results if the first one or two didn't do the job. And after probably 30 or 40 years of having these medications around, there is a brand new class of medicine that it's called a beta-3 agonist, and the medication is Myrbetriq. It's a brand new medicine now that's been out about 2 years. And Myrbetriq is a completely new type of medicine, works similar to the anticholinergics in that they allow the bladder to fill more and they reduce the urgency when the urge to go hits a person. And I've had a number of people who have not done well on the older types of medications who have done well on Myrbetriq. It seems to have few side effects. It can raise blood pressure just a little bit in a small percent of people. But Myrbetriq is a interesting new drug, and it's the first in class. We'll get more experience as time goes on. And there's a couple of other medications that we sometimes will use to treat overactive bladder, but all of them have potential side effects, and so we watch them very carefully. Some of the other treatments that are non-medical that work quite well, and they work really well in people young and old, and one of them is called percutaneous tibial nerve stimulation. So what we do is we take a small acupuncture needle and we put it next to one of the nerves right below the ankle. I can't tell you why stimulating a nerve at the level of the ankle turns off bladder function, or at least tones it down, but it seems to work. And typically we'll have someone come in once a week, little needles placed through the skin, and they're hooked up to a battery pack for 30 minutes. The first couple of treatments normally doesn't have much effect, but by the 4th or 5th treatment, many people will be getting improvement in their urgency and their frequency. Again, this is some of the types of treatments that don't have many side effects, because other than the nuisance of coming to the office to get the treatments, there's very few side effects associated with it. And so I've had people who can't tolerate the medications, or they're on the medicines but they haven't worked sufficiently. We're coming in for the PTNS, the percutaneous tibial nerve stimulation treatments, have proven quite effective. Another fairly new treatment is called Botox. And Botox is a muscle paralytic. For those of you that don't like your wrinkles, Botox injected in the face can relax the muscles below the wrinkles so they're less likely to show with facial movements. Botox also partially paralyzes the bladder muscle. So the medicine lasts about 6 months. It's a little office-based procedure. We're able to do these little injections in the office, and it's got about a 70%. So 7 out of 10 people will get substantial improvement in their frequency and urgency, and may even get dry with the use of Botox. A small percent, the medicine will paralyze their bladder enough that temporarily they won't be able to empty the bladder very effectively, and we teach how to do a catheterization technique where you may have to drain your bladder for the 6 months or so. That's a couple of percent where that occurs, and so the fear of that keeps a number of people from wanting to use the Botox. But in those that use it, it can be dramatically effective, especially for men and women that have been suffering for this problem for a long time. The urology guidelines state that using indwelling catheters is not a normal treatment for overactive bladder. And that's true. We ought not to be using catheters as a rule for treating incontinence and other problems with overactive bladder. I will do that temporarily sometimes. If someone comes in and they're getting up 10 times a night and they're just exhausted, or someone's traveling and they don't want to deal with the limitations of a frequent urinary incontinence or getting up to the bathroom all the time, having a catheter in place may give them the confidence to be able to ride on an airplane or stay at someone's house for a short time. Occasionally I will use catheters long term, especially if it's the difference between someone being able to stay in their own home versus having to go into a nursing home. The catheter has certain risks that occur over time, but those might be substantially less than the loss of quality of life by having to move out of their home situation into a long-term care facility. So catheters are an option to be used either short-term or rarely long-term. So treating mixed incontinence, which is a combination of the stress incontinence and the urge incontinence, is often a matter of just deciding which one of the two problems, either the stress or urge, is worse. Where this is important is a number of people will be treated either for the stress incontinence or the urge incontinence, and they feel they're not getting better. Well, what I found sometimes is that the medications that treat the urge incontinence may be working quite well, but when we come back and say, how are you doing? They say, I'm still leaking. Well, what they're doing is now leaking from the stress incontinence problem. If we manage the stress incontinence, then treating the urge component becomes much easier. So if we're able to identify that both components exist, then I find that we just need to manage expectations and just say, as long as you understand that there's more than one thing going on, we're going to treat part A first, and then we'll go back and treat the second part. We often find that if people are patient with the process, we can get substantial improvement. So in summary, treating overactive bladder and incontinence in people as they age is similar to treating the same problems in people as when they're younger, except there's a few added issues that we need to pay attention to. And ignoring those can be the difference between successful treatment and making little ground and trying to manage this significant quality of life problem. Except for those that just have functional incontinence. Either they're unable to get to the bathroom or just aren't aware, for whatever reason, that their bladder function, then excluding the functional component, 90% of people can get meaningful improvement in their overactive bladder and incontinence symptoms with effective care, as long as we're paying attention to the age-specific issues that need consideration, especially the constipation. All right.